A very striking statistic is that since 2010, the high-risk maintenance backlog in the NHS, and high risk here being defined as kind of a credible risk to safety of patients or staff, has quadrupled.
Hello, and welcome to the IFS Zooms In. I'm Christine Farquharson, Associate Director at the Institute for Fiscal Studies. For those of you who are joining us from holiday, I hope you're having a lovely break. For those of you still chained to your desks, I hope you take some comfort that the IFS never rests. And so over the next few weeks, we're bringing you a series of briefings looking at key areas of government. How have they performed in recent years? What are the big challenges facing the new Labour government? And, most importantly, what could the government do about it? Today, we'll be starting big. We're looking at the NHS, the UK's biggest public service, and one of the public's biggest priority areas. With such a big topic to tackle, I'm lucky to be joined by my colleagues Max Warner and Ben Zaranko, who are some of the nation's foremost experts on what makes the NHS tick. Pressures and problems in the NHS need no introduction. Indeed, Wes Streeting, the new Health Secretary, has already told us that there's worse to come and asked for an investigation into NHS performance. But there are bigger, longer-standing issues that we do already know about. So, Max, Ben, what are your biggest priorities? What would be at the top of your inbox if you were in Wes Streeting's position?
I think mine would be this worrying and persistent hit to the productivity of the NHS, because I think without addressing and solving that, you are going to struggle to relieve the financial pressures on the service, and you're going to struggle to achieve the waiting time improvements that Wes Streeting promised during the campaign.
Okay, productivity. Max?
I would have to agree with Ben, actually. I think my number one priority would also be productivity. As Ben says, productivity interacts with everything that we want the NHS to do. It, directly links what we're giving the NHS and what it's actually performing. And I think particularly at the moment, as we've talked about on lots of podcasts, the challenging fiscal situation for the new government means they cannot be just putting a lot of money in the NHS, and they're very upfront about that. And so productivity is even more important than it would already normally be.
Okay, so I think productivity sometimes gets a little bit of a bad reputation. People think that it means, what we really need are doctors and nurses working themselves into the ground, running instead of walking, getting more out of every hour. What does productivity actually mean, Max? And in the healthcare kind of system, is it just about getting people to move faster and do more quickly?
So big picture, productivity of any kind of system, including the NHS, is trying to relate the inputs into a system. And for the NHS, we might think of the inputs as, for example, staff, so doctors or nurses, but also things like medicines, equipment, the use of hospital buildings, all of these different inputs and how they relate to the outputs of a system. And for the NHS, we might think about the number of patients treated or the quality of that treatment. So big picture productivity looks at how all of those inputs go into the system and how that translates into outputs. And broadly, this fall in productivity that Ben alluded to is really because we see more inputs going into the system and more or less don't see a big increase in the outputs coming out of the system. So that's how we might want to think about productivity. I think you're right that often productivity for staff on the ground can have kind of negative connotations. And productivity is not just about how hard staff work. I mean, that is a factor, of course, in productivity, but there's so many other factors that matter for productivity and different measures and different things I'm sure we'll get onto that really can influence what's happening with productivity.
Okay, so Max is not fully on team cracking the whip. Can you give us a sense, though, of, this productivity challenge? Is this something that's long-standing? How big is it? Big picture, why is this the big issue?
Productivity is always an issue in any service, any public service. It's always desirable to do more or better with the same resources. But pre-pandemic, say the decade broadly pre-pandemic, or even the 2 decades, NHS productivity and healthcare productivity in the UK was growing. Actually, it was growing faster than productivity in other public services in general, but probably slower than economy-wide productivity. So there was productivity improvements. Then during the pandemic, we see this huge reduction in productivity. Now, during 2020, I think that fall in productivity was widely expected. We put a lot more resources into the system, and actually we cancel a lot of things to free up capacity and make sure we can handle the surge in COVID patients. I think what's really concerning is although productivity has bounced back a little bit from its 2020 kind of worst point, it's still far below pre-pandemic levels. So that's across lots of different measures. The ONS measures, NHS England now themselves are looking at productivity. They estimate that in the acute hospital sector, in last financial year, productivity was about 11% lower than pre-pandemic. So there's lots of different numbers, but those are the kind of magnitudes we're talking about. And one of the really concerning things, actually, is, as I said, there was a bit of a bounce back between 2020 and 2021. But big picture, if you look over the last couple of years, we haven't really seen big improvements in healthcare or NHS productivity in the last couple of years.
Wow, 11% lower. So if you had 10 doctors before the pandemic, you now need 11 doctors to treat the same number of patients, roughly.
Broadly, that's right, yes.
That's an incredible drain on NHS resources or pressure on NHS spending. Ben, I mean, that's a huge difference. What do we know about what's behind that? What's driving that?
Not as much as we'd like. One way to think about it, I understand that the NHS is complicated and it's a bit difficult to think about the outputs of a service like the NHS when it's treating so many different types of patients with so many different types of illnesses in so many different ways. But I think that one way to think about why we might have seen this is that we've got the input mix wrong. Now, that's like a technical way of saying we've added lots and lots of staff and we haven't necessarily added the things that those staff need to work most efficiently. So if you think about, imagine a kitchen serving in a pasta restaurant, and it's got a certain number of hobs, a certain number of work surfaces, and you double the number of chefs. Eventually, you're going to run out of hobs. You're going to run out of work surfaces. You're not going to double the amount of pasta dishes you can serve. And I think that the NHS is, in a way, from the analysis that we and others have done, it looks like something similar is going on, and where you've seen a big increase in the number of nurses, doctors, clinical support staff. Maybe you've not seen the same increase in the number of hospital beds. Investment in the digital equipment and IT that those people need. You haven't seen the same increase in the number of managers who are the ones sorting their payroll, sorting their rotas out, making things tick along. So I think that's at the forefront. I think that seems to me the most likely explanation. I think there's also potentially some signs that more burnout of staff during the pandemic. Maybe people aren't doing as much unpaid overtime as they were previously. That's something you hear. I think there's been a bit of a shift in the experience and the skill mix of the particularly the nurse workforce, maybe more newly qualified nurses, fewer of those much more experienced nurses that we know add a lot of value. Also a shift in a lot of where the nurses are coming from internationally. Rather than recruiting heavily from Europe, there's been much more recruitment from places like India, Nigeria, the Philippines. And I guess one question is, will it take those nurses a bit longer to maybe get used to NHS procedures? I think that's a big unknown question. And, I could go on for ages, but basically it's a big complicated system. There's never going to be one single answer. But if I was sat in front of Wes Streeting, I would be saying, you can't just prioritise frontline staff. You need to think about the other things that allow those staff to work productively.
I remember during the pandemic when I was volunteering at the Nightingale, and it took literally 6 hours on my first day to get me set up on the computer system, because it took probably half an hour for the computer even to turn on. And I don't care because I'm a volunteer, right? Like, my time's not worth anything. But if you're an actual staff member, that must be incredibly frustrating and just an incredible time suck to actually getting the job done that you want to be there and want to be delivering.
Yeah, it's very hard to see this in hard data often. Some of this stuff won't be recorded. But if you talk to doctors and nurses and other people who work in hospitals, there's just examples coming out of their ears of, I was supposed to put this blood test in a tube and it takes it to the lab, but the tube's been broken for 6 months, so I have to spend 20 minutes walking across the site to get it tested in the lab, and then I couldn't find anyone to do it. And then, that stuff just sucks up time and effort and money. And I think that's one reason why the productivity problem has caught up with us, because we maybe haven't sufficiently invested in those other important inputs.
Yeah, I mean, that makes a lot of sense. And I think that kind of ties into what Max was saying, that productivity isn't always a dirty word, actually. Sometimes if you get the support systems in a better shape, that makes frontline staff's lives better as well.
Work smarter, not harder.
Yeah, big motto for us at IFS.
Yeah, I think that everyone should be in favour of doing more with less. And I think that if it's a dirty word, we should think about how we communicate that, or how the NHS communicates that. But it's unquestionably a good thing that we should all be aiming to improve.
So I'm totally signed up to that. But I wanted to ask you, one thing that we often hear about productivity is, well, what we need to do is have productivity gains, and then that's going to cut down on the amount that we need to spend on the NHS, or the amount that we do spend on the NHS. Is productivity like a silver bullet that's going to fix the public finance side of this, or is this really about improving services and improving staff's lives?
I think this is a little bit nuanced. I suspect in the short term, if you were to magically unclog whatever's clogging the NHS, if you were magically able to, get rid of that 11% productivity hit overnight, I suspect what you'd see is more patients going through the system, you'd see waiting times fall, you'd see performance metrics improve, hopefully public satisfaction improve as well. You'd basically see the NHS get better. You'd probably end up spending a very similar amount. I think if you look further into the future, it might then allow you to spend less than you otherwise would have done. Maybe you can get away with employing slightly fewer people. Maybe you can spend a bit less to deliver the same quality NHS that the government desires. But I think in the short term, it's not a magic solution to the financial pressures on the service, just because the NHS is performing so much worse than we'd like it to, and that it is supposed to be.
And on that, you mentioned waiting times. So we saw some pretty ambitious targets in the Labour Party's manifesto around waiting times, or rather ambitious because they wanted to actually meet the targets that have been in place for quite some time and not been met for quite some time. Is there any world in which that ends up being deliverable?
I think it's certainly on the ambitious end of the spectrum, but I know you've looked at this in a bit more detail, Max. What do you think?
Yeah, I think it's certainly possible. So I think the key target here is that for the elective waiting list, so that's people waiting for pre-planned care, things like classically like hip and knee operations, cataracts, but also mainly outpatient appointments. The key long-running target is that people should be treated within 18 weeks of being referred to care by their GP. Now, we're very far away from meeting that at the moment. Indeed, it hasn't been met for approaching a decade now, so even pre-pandemic performance was hard. And the Labour Party have said in their manifesto that they want to return to achieving that 18-week target broadly within this parliament, this first parliament. Now, is that possible? I would say yes, it's possible. Is it likely? I think at the moment, probably not likely. Our modelling would suggest that's going to be very hard to achieve. And I think the nuance here, and this is always the risk with these kind of targets, is that there are good ways to achieve a target and bad ways to achieve a target. A good way to achieve the target is the NHS continues to treat more people and, the waiting list falls down, you treat people faster. A slightly more concerning way to achieve that target is to ration the number of people who can join the waiting list. And indeed, if we look at the moment, the NHS is treating more people from the waiting list than pre-pandemic, and that's good for getting on this kind of thing. But actually, the number of people joining the waiting list remains really quite flat at pre-pandemic levels. That is one of the reasons why the NHS waiting list is not quite falling at the moment, but, it's more kind of flatlining. In part, it's because the NHS is doing really well, and that's great. They're treating more people. It's in part because actually not as many people as we might expect are joining the list. And again, that helps the targets. But again, the targets aren't the only thing.
Yeah. So one thing that we've heard from Wes Streeting is a kind of interesting political economy change of tack, where he's increasingly talking about the health service as a driver of labour force participation or employment or economic growth. And I think that ties in, or he wants that to tie in very closely to this waiting list question.
Yes, he's actually said that one of the key new objectives of the Department for Health and Social Care is to drive economic growth. Yeah. And, there's been a lot of concerns about the rise in health-related inactivity in the labour force, about the rise in demand for health-related benefits. It's been hypothesised that one reason for that is poor NHS performance. There's some evidence for that. There's some evidence that actually that's not the main factor, because a lot of people on the waiting list, for example, are not actually working age or not in work. But clearly people's health does matter for things like their labour supply, how much they can work. And so there's definitely a big focus on that at the moment from Wes Streeting. Though, of course, it seems uncontroversial to say that the primary purpose of the health service should probably still be just making people healthier. And, there are benefits to that, but also that in itself is a desirable objective.
Yeah, absolutely. So Max, another thing that we heard a lot about during the campaign was around the 40 new hospitals, or the new hospital program. I think this was a Boris Johnson 2019 election promise that kind of understandably ran into some issues around the pandemic. Labour then recommitted during the campaign. And then it sounds like that now has been dropped in Rachel Reeves' statement a couple of weeks ago. Where are we with that?
So, yeah, the new hospital programme, as you say, has been a programme that's long had some difficulties, I think. I think it's relatively uncontroversial to say that the NHS estate, so hospital buildings and, other NHS buildings are often have lots of problems, are often quite old. We've talked before, there's a large maintenance backlog. So a huge amount of maintenance that should be happening is not happening, and that's building up. A very striking statistic is that since 2010, the high-risk maintenance backlog in the NHS, and high risk here being defined as kind of a credible risk to safety of patients or staff, has quadrupled. So there's a huge amount of kind of challenges in the estate. And so the idea of building new hospitals, improving existing hospitals, I think across the political spectrum has been desirable and actually comes back to what Ben was talking about earlier about this capital investment and the importance of these kind of things. Now, as you say, this was originally a Conservative programme when they were in government. They were very much a long-run programme. It's going to take a long time to build these hospitals. And in the Labour manifesto, they recommitted or committed to maintaining or continuing the new hospital programme, and often talked about the local areas that would still get new hospitals during the campaign. Now, since Rachel Reeves and Wes Streeting have come into office, I think the mood music has changed slightly. I don't think they have yet to say we're not doing the new hospital programme, but they've been clear that they are thinking of reviewing it. Now, I think there are some, very valid reasons you might want to review it. It's a programme that's struggled, maybe hasn't received the funding or the stability that it needs. But also, I think we can't not see this in the wider fiscal picture that Rachel Reeves is facing. So at the moment, what's going to happen to the new hospital programme is somewhat uncertain. But again, the direction of travel of the need to invest in new capital, the estates, is clearly needed. But I also think, and maybe we'll come back to this, there's a risk that we repeat the mistakes of the past. One of the reasons that the NHS estate and capital is struggling is because in the 2010s, when the NHS was under a lot of financial pressure, money was moved from capital to resource. It's not necessarily going to happen again, but, the mood music sounds like...
It happened last year.
Well, it happened last year. I mean, under the new Labour government. We don't know if it will happen or not, but again, it's the kind of thing that we should be trying to avoid if we really are serious about productivity.
Yeah, I think we kind of hear that all over the place, that there's this short-term pressure. We rush in to try and find the money to fix the short-term thing that's sitting right in front of us, and some of those longer-term priorities that might help us start to get out of the hole end up suffering. And I think that comes in capital spending. It also comes when we think about sort of prevention and moving care out of hospitals. So before we move on to some of the other challenges beyond productivity, I want to ask each of you, if you were Wes Streeting, what would be the kind of 2 or 3 things you would be looking at first to try and think about addressing the productivity challenges, Ben?
I think you've got to do short-term, difficult and potentially unpopular things like, the big picture things, you have to prioritise capital. You've got to find a way to stop money getting raided from the capital budgets and put into resource, and you've got to find a way to resist those short-term pressures and prioritise investment in things that will yield results further down the road. And that's easier said than done, but I think you might have to think about things like hiring restrictions or a very hard-nosed approach to, the in-year financial pressures or the financial pressures the NHS is under, and forcing the service to live within its day-to-day budget in order to protect and prioritise capital spending. I think that's true within hospitals. We can come back in a moment to questions about how to shift care outside of hospitals. But I think that when we're talking about the spending review this October, and then there's the bigger one, the more important one next spring, I think in negotiations with the Treasury and with the NHS, I think that it's got to be about more than just frontline staff and finding a way to, early in the Parliament, maybe take that political hit in order to invest in things that might yield results further down the road.
Okay, so quite bitter medicine from Ben. Max, what would you recommend?
I firstly would agree with Ben. If you, obviously from an NHS perspective, the desirable thing is to maintain day-to-day spending at its current level and massively increase capital spending. I think that's going to be hard fiscally. If you've got the same overall budget, I think there has to be a reprioritisation towards capital spending a bit. And as Ben says, that is going to require politically challenging decisions. Maybe we have to delay progress on the 18-week waiting list target because we want to this year really focus on investing in capital in the estates, and we know that will give us benefits in future years. Really trying to make those hard decisions. I think other things that you could do, I think one really important thing is just resolving the doctor strikes.
Yeah.
The doctor strikes caused substantial disruption to the NHS. At least in NHS England's analysis, they think that it's responsible for some of the productivity shortfall, is just the disruption from doctor strikes. Trying to resolve those, as it seems might be happening, I think is desirable from a productivity perspective. So that would, as well as the kind of bitter medicine, I think resolving the strikes is something that's worth doing.
Though they're a little bit in tension, aren't they? I mean, I agree with you that the strikes have been, if nothing else, just taking up manager bandwidth. But I suppose that, the main way you resolve the strikes is you chuck money at the problem. And what was the phrase in the 1950s? You stuff the doctors' mouths with gold. And that's one way of resolving the strikes. But again, that adds to the pay pressures and it makes it more difficult to prioritise capital. So there's a balance to strike there. But I think that there's no route to a healthier, more successful NHS in the medium term that doesn't go through higher capital spending. I just cannot see one. And I think that you've got to be willing to take a hit to make that happen. But I accept that might make it more difficult to maintain peaceful relations with all of the medical unions.
I think that's right, though I'd push back slightly. I mean, in a very narrow sense, resolving the junior doctor strikes has a very high rate of return, in a very narrow sense, right? The pay bill increase from the New Deal is maybe going to cost about $1 billion a year. The estimated cost of the strikes last year were maybe 1.7 billion, 1.9 billion. So in a very narrow sense, that's got quite a high rate of return, not even accounting for the productivity hit. Now, of course, and Ben's getting ready to say this, and I completely agree, there of course is a risk that by giving a great pay deal to one doctor's group, suddenly the nurses or the consultants are going to start appearing. And they are far more expensive because they're much bigger groups or have much higher pay. So, there's risks here, but I think trying to toe that line, and of course it's challenging, but I think it is important to try and resolve the industrial action as well as all of this, capital spending.
I guess there's also a question about what other groups of medical professionals want today, but also what situation are you setting yourself up for tomorrow? And is there a sort of dynamic element to this where caving in early in your new government makes it easier and more attractive for unions to ask for more later on as well?
Absolutely. These are challenging issues. But I think it's important to resolve the strikes. But if we're being very pragmatic and a very tough decision-making health secretary, we have to recognise the NHS, to use an economics term, has massive monopoly power here. The NHS does employ the vast majority of doctors and nurses in the United Kingdom. And so, that is one of the reasons why pay has been kind of held down in real terms, really, or falling for a long time. But the number of staff working in the NHS is just increasing substantially over this period. So, the doctors and the staff groups have bargaining power, but actually you as a health secretary have substantial bargaining power here, I think.
I think we should talk about GPs here as well, because the junior doctor strike looks like it might be wrapping up, and then lo and behold, we've got a new one just emerging, which is that GPs are going to be working to rule, which effectively in practice looks like a cap on how many patients they're willing to see each day. And given that the service seems to operate on the assumption that GPs will cram in extra patients, do extra hours, etc., that's effectively like a restriction on primary care capacity, GP capacity. We've talked mostly about hospitals so far, and I think that's partly because it's what we do most work on. It's partly because that's where the data is best. It's partly because that's where a lot of the high-profile targets are. It's where most of the spending goes. But the care that's provided outside of hospitals is also extremely important. And I think that often people's first interaction with the service is with their GP. And if you struggle to get access to your GP, that's often what people have in the forefront of their mind when they think about the NHS's travails. This is what I mean, though. If the GPs have looked at what the junior doctors are doing and concluded strike action works, taking a tough line works, being militant works, the GPs may well go down that route. Nurses may do also. Maybe you'll see Unison and the other big unions that represent clinical support workers go down that route. And you end up with, a $1 billion bill for the junior doctors. But the dynamic effect, as you say, Christine, could lead to this being an expensive route to start going down.
Okay, so I was told to try and find disagreement between Ben and Max, and I think we've successfully found at least a little bit of disagreement on what they would advise West Reading to do on workforce questions. What about this broader question of how services are organised? So we talked a little bit about, as you say, Ben, we focused on hospitals. There's a whole other ecosystem of care in the NHS, in GPs, in pharmacies, in clinics, and a lot of stuff that happens before you get to that hospital entrance. So, and I think we've heard from many different health secretaries at many different points in time that what we want to do is bring care out of hospitals and into the community, and that's going to be better for patients because it means they get seen more quickly and have better health. It's also potentially going to be better for the public finances because that care in the community is cheaper. That's the kind of pitch that we've heard a lot. Does that stack up? Is there any chance of us actually being able to achieve that?
It's certainly something we hear a lot about. I think that it's definitely in that category, which is a very big category, admittedly, of easier said than done. So the pattern of the past couple of decades, effectively, is the NHS growing to be an ever bigger share of what government does, and then within that, hospitals growing to be an ever bigger share of what the NHS does. So if you look at a chart of what's happened to the number of hospital doctors or consultants, it goes very sharply upwards. We've seen a big increase just in recent years. If you look at the same chart, but for the number of GPs, it's basically flat. So there's a problem there of where resources are going, and there's a question of, are we able to recruit enough GPs and retain them? So I think that the desire to move more care outside of hospitals isn't a new one. I think it's a very sensible one. I think that the question of how you do it is something that I don't feel qualified to advise on. But I think that there's clear attractions in terms of it being cheaper to treat someone in their own home than have them occupying a very expensive hospital bed, particularly when hospital beds are in such short supply. I think that it often comes with a discussion about prevention, which effectively is like demand management, try to stop people from demanding expensive healthcare further down the road by intervening earlier. Again, I think there's a very good case for that. There's lots of stories. I think if you look at cancer care, for example, I think the UK doesn't come out doing particularly well in international metrics, and often that's because we're not very good at catching things early. So often people then present with more complicated, later stage cancer. They have worse survival outcomes, and it's more expensive to treat. So there's a case to be made, an argument to be made that better early interventions, more screening, those sorts of things could help save money further down the road. Of course, there's also a risk you just uncover more people with things that need treating and you're not saving anything at all. I think there's a good case for trying to prevent people from getting sick in the first place because it's good for those people to live healthy, happy lives. If you're taking the hard-nosed fiscal perspective, if you prevent someone from catching one thing and they live a bit longer, they're going to eventually catch something else. Like it's if anything, maybe you're delaying the cost. But it's a bit like the smoking debate, right? If you stop someone from taking up smoking, they don't catch lung cancer when they're in their 60s, but they end up living longer and dying of something else, potentially much more expensive. So you prevent one thing, but you can also create demand elsewhere. So I think that there's a good case for these things. I think they're probably likely to be very good for the recipients of that care. People don't like being in hospitals. Preventing things is obviously better than catching it later. But I'd be nervous about banking too much on that as the sort of solution to the NHS's financial problems.
Okay, so I think there might be a sort of fact about the world that's underlying that it would be good to just draw out. So I think what you're saying is if you prevent someone from catching something that is going to kill them, something else will kill them later on and they'll have lived longer and so may be just as expensive. If you prevent someone from catching something that, is going to need them to spend a week in hospital and then they're going to go back to living their regular life, then that does feel like a fiscal benefit. And so I think what you're saying is that actually most of the work that hospitals do certainly is in that first category of treating people at or towards the end of their lives.
That's where a lot of health spending, a remarkable percentage, I don't have the number at my fingertips, but takes place in people's last 6 months of being alive. So if you might push that back a couple of years, and that's great, that's a few more years for people to spend with their families or enjoying their life. But the NHS eventually faces more or less the same bill for the final 6 months. It just happens later. I think that's clearly not perfectly true, but I think that's a reasonable first approximation of how to think about these things. But I think that that's not a reason not to do this stuff.
No, of course. And I think we've sort of slipped back again into thinking about hospitals and secondary care. If we take the sort of other end of the prevention spectrum and we really think about public health budgets, what do we know about how public health spending has been changing, and particularly how that stacks up against the sort of more acute NHS spending?
So public health spending, I mean, firstly, just to talk about magnitudes, because I think that's really important. The NHS is so big. Public health spending is pretty small within the NHS. It's not happening via the NHS, but within the healthcare system, public health spending, I don't have the exact number to hand, but is in the kind of mid single digit billions. Primary care is, say, 10 billion a year. Lots of these things that are not the acute sector are actually not very expensive or big. And indeed, just coming quickly to something we were talking about earlier, again, you could make the difficult decision to take a little bit from the acute sector and give it to the primary care or public health. Now, that would actually be quite a small percentage decrease for the acute sector and quite a big percentage increase for some of these other areas that are, depending on your perspective, quite cheap to run or somewhat under-resourced. But when it comes to public health spending, that covers a range of services like alcohol prevention, drug prevention, sexual health, some child health stuff. I think what matters is the level, and that has in general fallen in real terms in recent years. I also think something that's really important is the allocation of that public health money. And myself with some colleagues did some work, a year or two, maybe 3 now, showing that actually public health funding is just remarkably poorly allocated. Relative to government's own assessments of need, some places, some councils essentially are getting double what they should be getting, and some are getting half of what they should be getting per person. So the level matters, but also that allocation is really important too when we think about public health spending.
Absolutely. And I think that kind of ties into some of the wider themes we've talked about a lot on this podcast of other areas of public services that are doing things like supporting people living in poverty, supporting people in poor housing, supporting people who are struggling with obesity or have poor nutrition. Or there are a lot of wider public services that have seen those sort of services that might support public health really cut back, particularly local government.
And I think you can make the case. I mean, I think where does $1 billion go when you think of the huge acute sector versus where does $1 billion go in terms of actual health outcomes if it goes to primary care or if it goes to public health, or even where does $1 billion go for health if you actually put it in something that's not quite traditionally in the health and social care system, but as you say, actually feeds into health. I think there are very interesting questions here where it's not always obvious that the best thing for health or even the NHS is just put more money in the acute sector, as sometimes has been the trend.
Okay. Ben, would you agree? Would that be where you would put your marginal £1 billion?
Is it outside of the acute sector?
Yeah.
I think so. I think that the case for that is pretty good. I think you're going to have to do a bit. We're very unlikely to be able to just freeze how much we spend on hospitals, not least because we're going to be giving up to them big pay rises. But I think that it's going to be the big things what Max said is basically you can shave a little bit off in percentage terms the hospital's budget, and that can actually go quite a long way elsewhere. And that's also true if you take a broader sweep of public services. You can shave a little bit off the NHS and you can give a transformative amount to the legal aid budget, which might prevent people from spiraling into losing their house and getting sick and things like that. So there's a broader question of whether the NHS is the right place to be putting the marginal pound, and then within the NHS where it ought to be going. One sort of interesting trend of recent years has been moving things into the NHS umbrella, because politicians seem to find it easier to give the NHS budget increases. So if we're not unable for some reason to give councils extra money for social care, let's just give the NHS more money and have them send it to the councils. Or if we can't spend more money on social care services to make sure people are getting what they need, well, let's just have the NHS spend £6.5 billion every year on a continuing healthcare, which is really a social care programme. So we've been recently moved the Health Education England budget, the training budget. We've put that inside the NHS umbrella. We've put the NHS Digital, the data stuff, but let's put that inside the NHS England umbrella. So we've now got this monolith that does everything, and it has to stop somewhere. But a lot of those allocation questions are now increasingly within the NHS as well as just across the broader sweep of the public sector.
Yeah, that's fascinating. So we've talked a lot, I think, about the allocation of resources within the NHS across primary versus acute care, across community versus sort of secondary care, across capital versus day-to-day spending. Let's take a step back now and let's think about the kind of total amount of funding on the table. So Max, break it down for us. The NHS costs about $200 billion a year to run. What does that actually mean in terms of wider public service spending?
That's right. So the NHS in England's budget is about 180 billion. UK health spending as a whole is about 220 billion. So I think the first way to think about that is in terms of how much the government spends overall. So healthcare services are about 18% of what the government spends. So for every £5 of tax that people pay, about £1 of that is going to healthcare, and almost all of that for the NHS itself. Thinking beyond what just the government does, healthcare spending in the UK is about 8% of GDP. So all of the resources in the economy, about 8% of that is going towards publicly funded healthcare in the UK.
Is it enough? Is there any way that we can get away with not increasing that total quantum of funding? And if we're going to increase that total quantum of funding, how on earth do we go about doing it in a way that doesn't repeat some of the mistakes that we've seen in the past?
The first thing to say is that there's no definition of enough. It's within the eye of the beholder. I think you can look at how the NHS is performing relative to its various targets and say, well, it comes back to this productivity question, but you can at least argue that it clearly doesn't have the resources it needs to perform at the level at which it's expected to perform. So maybe you can make the argument it's not enough, though if you manage to unblock some of these productivity issues, that may no longer be the case. It's not just about cash. I think what's inevitable is that going forwards, the health budget is going to have to increase. And we're going to have to devote a bigger share of our national income towards health. Just to give you one simple reason why, between now and 2040, the number of people aged 85 and above, those are the people who use healthcare most intensively, is set to increase by more than half. Now, these are the guys who are, regular healthcare users, spending long spells in hospital. I mean, think about my grandmas, who fortunately neither of them know what a podcast is, so they won't hear me say this, but they're in the GP every other week. So these are the people who are using it a lot. And it's just inevitable that we're going to have to spend more on healthcare if we're to meet those pressures. The question is, how can we do that in the most efficient way, make use of that money most productively, and can we, by spending more on smart things, investing in capital, making better use of technology, thinking about the appropriate mix of the workforce rather than just blindly sticking to what we've got, but bigger, can we limit the financial pressures that creates through some of those policies? But I think there's no way in which the budget goes anywhere but up.
And Max, what do you think? What would be your route to increasing the healthcare budget and getting as much as you can out of that?
It's a good question. I just reiterate and even go a bit further than Ben. Ultimately it is a political choice what is enough. There is not a right answer, and it is a perfectly valid political viewpoint to say, look, I think the NHS should do less, and therefore I'm going to give it less money. I'm going to maintain its money. The trend of funding going up is very much of, are we going to maintain or even try and improve services? If you want to even maintain the current quite poor performance, as Ben says, funding will have to go up. Mm-hmm. So how will you achieve that? I mean, if you want to do any increase in public spending, there's fundamentally three options. You spend less elsewhere, you raise tax, you borrow more. Now, this is very much a longer-term pressure. This is probably not something that you can sustainably just borrow permanently to fund a continually larger increase in the NHS. So you fundamentally get down to fiscally, no matter what money you're putting in, and of course productivity matters there, but I would stress, even with big productivity improvements, you're still going to need a lot of money. To just give two examples over the kind of, since I think about 97 to pre-pandemic, NHS increased a lot what it does. About 20-25% of that came from higher productivity. The rest came entirely from more resources going into the system. Looking ahead, the NHS Workforce plan, a massive increase in the workforce, but also a massive increase in productivity. So productivity reduces the kind of trend growth rate that you need, but it doesn't eliminate it. And so you then come back down to the fiscal question of, if we're going to have a larger and larger share of GDP going towards healthcare, can we spend less on other things? Now, there are some small benefits of these demographic transition. We are going to be able to spend less on education, for example, as we have an older population. That saves us a little bit of money, but nowhere near the saving from education is nowhere near enough to offset the increase in healthcare pressures. So then it comes, do we spend less on other things? Traditionally, since the 1950s, at least until the last couple of years, we've funded in part the big increase in health spending by falls in defence spending. That no longer looks quite as possible, given the challenges in the world stage and the increases in defence spending. So you're either going to need to spend less elsewhere, or as we've come back to, you are going to have to raise tax because you're going to need to fund a larger and larger share of GDP going towards healthcare services. And that's really just a challenge that parties of any colour in the coming years are just going to have to grapple with. And I don't think there are easy solutions to get out of that.
All right. Well, I think on the IFS Zooms In, it always seems to come back to the fiscal trilemma: tax more, spend less, borrow more. And which path are you going to go down? Ben, Max, thank you both so much for a really informative and really interesting look across all of the different challenges facing the NHS. We've heard about the sort of big picture macro pressures on the health budget and potentially the inevitability of some of the increases in that total budget if we want to maintain services where they are. But we've also heard about the really big challenges with productivity and trying to get the most out of that money that we can, and particularly some really interesting choices and potentially quite politically difficult choices on how you spend that budget in order to try and get the biggest bang for your buck. Thank you for listening to this episode of the IFS Zooms In. We'll be having more of these briefings covering other public services as well as wider issues like tax or pensions in the coming weeks, so do stay tuned. And to see more of our work in the meantime, you can visit www.ifs.org.uk. To further support us, do consider becoming a member for as little as £10 a month. You can find out more in the episode description, and we'll see you next time.